Cape Cod Broadcasting weaves the listening environments of 99.9 WQRC, Ocean 104.7, WFCC Classical 107.5, Cape Country 104, and CapeCod.com's website experience to reflect the lifestyles of the people who live, work, and play on Cape Cod. We hope that you enjoy this podcast.
I'm Laura Reckford, and this is Sunday Journal. I'm here in the studio with Dr. Jean Talbert, an OB-GYN at Cape Cod Obstetrics and Gynecology in Falmouth, who is one of the founders of the Substance Abuse in Pregnancy Task Force at Falmouth Hospital, and Dr. Sharon Daley, a pediatrician with Seaside Pediatrics, who is involved with the NAS program at Cape Cod Hospital. That's the Neonatal Abstinence Syndrome program. And Cheryl Bartlett, who is leading substance abuse prevention efforts at Cape Cod Healthcare. Welcome to all of you to the show.
Thank you.
We're talking about babies born addicted to opiates, and it is called Neonatal Abstinence Syndrome, or NAS. Let's start by explaining what NAS is.
Well, first of all, babies can be substance-exposed newborns, meaning their mothers during pregnancy took either prescription medications or illegal substances. A subset of those babies will have actual symptoms of withdrawal, so we call that NAS, Neonatal Abstinence Syndrome. It's unpredictable which babies will have withdrawal, so we monitor all of those babies carefully after birth.
And how big is this problem on Cape Cod? What are the figures at Cape Cod Hospital and Falmouth Hospital? Cheryl?
So we looked at our data over the past few years, and this is an increasing problem not only here in Massachusetts but across the nation, and certainly Barnstable County has significant issues, but there are lots of misinformation out there, and about 5.8% of babies born at Cape Cod Hospital are substance-exposed newborns, and at Falmouth Hospital it's 4.1% of the deliveries. So while it's rising, it's since 2009, it really isn't at the level that the community thinks that it's at.
Now, we know that there is a lot of news in recent months, recent years about the opiate abuse epidemic on Cape Cod, really across the region, across the country. Now, has that number of babies born with NAS grown in recent years? You said it's gone up a little bit. Do you have figures of comparisons maybe 5-10 years ago?
Oh, no, I would say it's gone up about 19%, I would say, from FY09 to FY03, Massachusetts, there was a 19% increase in SEN and a 61% increase in NIS. And Barnstable County has one of the highest occurrences of SEN and NAS.
And to put it into perspective, because you're saying 4% and different percentages, how many babies are born each year at each of our local hospitals, and so how many, and then how many are born with NAS?
So at Cape Cod Healthcare in total, there's been about 1,200 to 1,240 births over the last few years, and so 4% of that. Actually, if you add them together, 4% at Falmouth Hospital and 5.6%. So in terms of exact numbers, I don't have the exact number with me, but I think in 2014 it was 49? SEN?
46 for Cape Cod Hospital, but
Cape
that
Cod
doesn't
Hospital.
include Falmouth.
Right.
Mm-hmm. Now, when a baby is born with NAS, what are the symptoms?
First of all, we can't predict how many babies will have symptoms, but generally over half will. And anywhere from the first 24 to 96 hours or so, babies may start to have symptoms of withdrawal. There are 3 types of symptoms that we see. First of all, there's the central nervous system. Babies can become very irritable. They have muscle stiffness, tremors. Secondly is what we call the autonomic nervous system. They have rapid breathing, nasal stuffiness, and temperature instability. And thirdly, the gastrointestinal system. These babies have trouble feeding. They often have diarrhea. They have difficulty sucking and swallowing and problems with gaining weight. They also can have intolerance to different formulas. Interestingly, they usually tolerate breast milk the best. These symptoms may or may not appear for several days. So as a matter of course, what we've developed in our program is a system where we observe these babies in the hospital for the first 5 days.
When we're talking about substance-exposed babies and NAS babies, which drugs specifically are we talking about here?
There are actually several drugs. Sometimes we know what the mom took, and sometimes we don't. Many of our mothers are in programs, so they're either taking methadone or Subutex, which is buprenorphine. Some of our mothers are using street drugs, including things like heroin, or prescription opioids, such as pain medications.
So those are the babies exposed to opiates. And when you use the term substance exposed, are we also talking about a range of different types of drugs?
Opiates are probably the biggest part of the problem, but other substances like cocaine certainly are out there.
And what has to then be done to wean the baby off opiates at that point?
Well, the first treatment is what we call non-pharmacologic. That means cuddling, swaddling, having a room with very dim lights, quiet voices, the mother's presence very frequently. The babies know their moms right from the beginning. They know their touch, their smell, their voice. So this is all very soothing for them. Babies are monitored every 4 hours for all the symptoms of NAS. And at some point, if the symptoms become more than these supportive measures can deal with, then we treat them with medication.
And what types of medication are needed at that point?
The first medicine that we use is a special form of morphine called neonatal morphine, especially for babies. We find a level where the baby is soothed and the symptoms of withdrawal are decreasing, and then we try to steadily decrease the medicine over, usually takes about 2 to 3 weeks. Sometimes additional medications are needed too, but morphine is the one that most often is used here and also at other institutions in the country.
Now, we're talking about 2 to 3 weeks, and then, of course, time goes by, and have studies shown that there are permanent effects from these conditions?
Most of these babies have every opportunity to do really well. The ultimate outcome for these children actually depends more on family and environmental factors when they go home from the hospital than what happens in the hospital. These babies thrive if there's a stable, nurturing home environment, and they have the opportunity to grow and thrive as any other child. So we spend a lot of time working with the mothers and the families to try to make a good situation for these babies.
I'm Laura Reckford, and this is Sunday Journal. We're talking about the issue of babies born addicted to opiates at our local hospitals, and also babies who are so-called substance exposed. And what about the mothers? Dr. Talbert, what are the different programs to deal with this before the baby is born?
Well, we've been doing a lot of work to work with the mothers. I think the most important thing is early identification. So as soon as a woman's able to reveal to us that she is using substances, whether they are illicit substances from the street or medications that she's been prescribed, we can start working with her on preparing for this birth. And I think that's very helpful. We found that the more information we can give the moms prior to delivery, the less traumatic the whole birth process is. And we can also encourage the mothers to spend as much time with their babies at birth so that hopefully we can decrease the incidence of the actual withdrawal symptoms, the NAS in the babies. So we've been doing quite a few things in our practice. Some of them we're trying out, and some things we've actually found already that are working quite well. We are trying to screen the mothers. We screen with questionnaires. We screen with just conversation, trying to make our office environment welcoming and not threatening, so that they don't feel like we're going to report them or turn them into somebody or treat them badly because they have a problem. Because we are feeling that this is a medical problem and not a problem not that the mothers are really trying to cause harm to their babies. In fact, in many women, this is a window of opportunity to seek recovery, because now they've got this baby coming and there's suddenly a different motivation to take care of themselves and seek help. So I've found it very rewarding to work with the moms that want to recover and try to help them find the right path. And it's different for everybody. And these treatments, some women do well with methadone. That's one of the medication-assisted treatments. It is the oldest standard medication replacement for opiate addiction. Other women do well with the buprenorphine, which is an office-prescribed opiate, a replacement medication as well. We generally do not try to have mothers withdraw from opiates during pregnancy. We find that may have actually higher risk for the pregnancy. So we would rather have the mother on replacement if she needs it, and take care of the baby after birth when we can actually see the baby and see what kind of reaction the baby's having to the reduced levels of opiates. When the baby's in utero, we don't know, and there are some risks that we've identified. So anyway, we work with the moms. We try to have them in some kind of stable recovery. If they had actually stopped using using the opiates before the pregnancy, and then they got pregnant very quickly, we work with them to stay off of the medications if they can stay clean being off. And lots of support services. We have support groups for mothers. We have counselors, a lot of counselors available on the Cape for mothers. There's a huge addiction treatment program in many different settings here on the Cape that can be very helpful. There's a lot of community services on the Cape that can be very helpful, that will come into homes and help moms prepare, help them to deal with the other stressors in their lives, because our lives are very stressful, and this doesn't help. So that we're trying to really communicate better within ourselves and the community, the services in the community, to kind of create a safety net and a network of help for these women.
When do you typically find out that a mother might be addicted to substances or opiates? Is it typically during the early stages, as you say, you talk to them, you give them opportunities to tell you, but do you have the issue of mothers maybe not telling you and they're actually giving birth and you're finding out? Does that happen?
That does happen. A lot of the moms that are still using heroin, still using the street drugs, don't access prenatal care and don't access it very, very early. And I think a lot of that is because they're afraid. They're afraid what's going to happen, and there's a bit of denial. And if they eventually come into our office, actually one of the red flags for us is if somebody does show up very late for prenatal care, we do, particularly inquire about, more than even the average patient, inquire about drug use, and often we'll ask to do a drug screen to make sure that they're not using, and if they are, to be able to get them into some services before the baby comes. We do occasionally, it's not many, it's a handful of women that never get prenatal care and do just show up in maternity in labor. And unfortunately, those babies tend to have the toughest time, I think.
Now, if a mother is in labor and giving birth, do you ever have it happen where that mother is actually going through withdrawal symptoms?
I can't think of any particular cases that I identified with that. I think, many of them have used and close enough to labor that they're covered for a little while, and then the problem is usually identified fairly quickly once they're in the hospital.
And Dr. Daley, I see you shaking your head.
We only had, in the past several years, one mother who was actively withdrawing when the baby was born, and her baby did have symptoms earlier than others, but we were on the lookout for it, and the baby ultimately did well.
And you had mentioned earlier, Dr. Talbert, about this idea that it can be dangerous for a mother to actually go off opiates or some of the recovery substances. The fetus is very sensitive to substances.
Yeah, and the fetus is genetically different somewhat than the mother, and so how the mother's reacting to withdrawing from the medications may be different than the baby's reaction. And like I said, we can't monitor the baby. And there have been, identified increased risks of preterm labor and some other complications of pregnancy that go with withdrawal. So there are some protocols for withdrawing moms that are on a low dose of replacement medication. There are some protocols for withdrawing them very, very gradually in the second trimester. But in general, if it's on into the third trimester and they are on a medication, we don't recommend trying to come off at that point. Many of the women come in and say, I want to be off this because they hear about the withdrawal in the babies. But we generally try to convince them to stick with what they're doing through the pregnancy, that we'll be able to care for the baby. We know what the baby's been exposed to. And then postpartum, and actually I'm not encouraging them to try to come off early postpartum because postpartum's a tough time. And there's a lot of relapses in the postpartum period. So we usually try to help them get through that, get their lives kind of stabilized, and then if they're really feeling strong and have good support, then start to work on withdrawing from the replacement medications. But it's not something we're in a big hurry to do if they're stable on what they're on.
And you referred to this briefly, but what is the psychological effect of a mother of giving birth to a child addicted to opiates?
I think it's a really, really tough thing for the mothers. Most mothers have they want to do the right thing for their babies, but in this situation they have a medical problem that they can't fully control, and and it's very, very hard for them, especially to see their babies withdraw. It's very painful, and many of these women also find that they're ostracized, even in the recovery community, that they may go to NA meetings or AA meetings, but if you walk in there 9 months pregnant, there are some people even in the recovery community that say, oh my God, she's using and she's pregnant too. I would never do that. And so there's a lot of shame, there's a lot of guilt. The support groups that we've started, I think, have been very helpful for that, because it's groups of women that have been through this. And I think only somebody who's been through it really can feel what these women feel.
We've worked really hard at Cape Cod Hospital to take a very non-judgmental approach to these women, because they already feel bad enough when they're there. And if we approach this as more of a medical problem and say, we're here to take care of your baby, we're here to take care of you and help you be a successful mother, that's going to work the best.
Mm-hmm. And as I think you mentioned, the hospital has a number of programs for the mother and baby after the birth. Cheryl?
Sure. Well, I think Dr. Talbert referred to the Mothers Supporting Mothers support groups, one associated with Falmouth Hospital, one here in Hyannis, and again, only women that have gone through this circumstance, so they understand each other and really can help each other through it. Both Dr. Talbert and another obstetrician in the Hyannis area have counselors from Gosnold through the Community Benefits Program at Cape Cod Healthcare, so that they can help with screening and counseling during the pregnancy. And we also most recently started a pilot program at Cape Cod Hospital, just weeks old, where we're working with Cape Cod Child Development's early intervention program, so they can actually meet the moms in the hospital so that they are familiar caregiver to them. This is a program that typically a mother would get referred to after discharge, and then somebody calls you who you don't know to see how you and your baby are doing. And I think there's a lot of fears of, is this somebody that may take my baby away from me, so they don't get the help that they could get.
And I was just about to ask about that, whether there is ever a situation where the Department of Children and Families is brought in.
Yes, absolutely. This is a reportable condition under the 51A law, and so they would come in and assess somebody that's been exposed to an addictive substance. And so we want to really work and try to keep these families together. Just because someone has this condition doesn't mean that they'll be a bad parent. And so we really want to give them all the supports that they can have. So this early intervention program, meeting the moms while they're in the hospital, is sort of a pre-admission screening and referral. And our hope is that we can increase those women who take advantage of this. If a child has NAS, they can stay automatically in treatment for 1 year, and if they continue to have any kind of developmental delays, they can have up to 3 years of free service for their babies. And it also gives an opportunity for a professional to have contact with the mother and hope that they can help them stay in their treatment program too.
And in the last minute or so that we have left, where should people turn for help?
I think any trusted professional that they know is someone that they can go to and ask how they may get referrals to the exact kind of treatment. There's a lot of different treatment options. Not one treatment program works for everybody, but we do have Gosnold on Cape Cod here. We have a lot of primary care practices that are increasing their awareness about the needs around substance use disorders and the treatment needs.
I've been talking to Dr. Jean Talbert, Dr. Sharon Daley, and Cheryl Bartlett. Thank you so much to all of you for being here with me today.
Thank you.
Thank you.
I'm Laura Reckford, and this is Sunday Journal.
This podcast is a presentation of Cape Cod Broadcasting, which is solely responsible for its content. Thank you for listening. For more information, please visit us at capecodbroadcasting.com.